Hey guys, welcome back to Midnight Med. This video is on migraine. A patient with a migraine will present with a pulsating unilateral headache that is often aggravated by physical activity. The headache may be associated with phonophobia, that is, sensitivity to sound, photophobia, that is, sensitivity to light, and nausea and vomiting. The headaches may be associated with auras, which are focal neurological symptoms that precede or accompany the headache. There may also be a prodrome, symptoms that occur before the headache, or a postdrome, symptoms that occur after the headache. The headache occurs in 4 phases: the premonitory phase, the aura, the headache, and the postdrome. It's worth noting that parasympathetic activation may also cause associated symptoms. And as we go through the pathophysiology, it might be worth reviewing our cheat sheet on cortical neuroanatomy, which you can find on our Instagram page at MidnightMed1200. The prodromal phase is punctuated by activity in the hypothalamus, midbrain, periaqueductal gray, pons, and some cortical areas. The symptoms that might be seen as a result of this activity might include irritability, yawning, sleep changes, and neck stiffness. Auras occur in about 30% of patients. These are visual, sensory, and motor and speech deficits that occur prior to the onset of a headache. The pathophysiological foundation here is cortical spreading depression, which is a period of depressed neuronal activity that moves across the cerebral cortex. It's associated with a preceding local hyperemia and a consequent spreading oligemia. So there's an increase in blood flow locally that comes before, and then a spreading decreased blood flow that comes with the cortical spreading depression. The headache itself is associated with activation of nociceptive trigeminal nerve fibers, the periaqueductal gray, and the hypothalamus. There also appears to be an association with sensitization to stimuli in the central nervous system and altered function of descending neuronal modulation. And finally, the postdrome is similar to the prodrome in terms of its pathophysiology. Risk factors for migraine include a family history, which increases an individual's risk threefold. In fact, there are genetic links that are associated with mutations in ion channel genes or vasculature. Migraines are also more common in females. This could be a hormonal effect, because we do see a decrease in migraine incidence in females after menopause. Stress and sleep changes, either too little sleep or too much sleep, also increase risk of migraines. Smoking and alcohol are associated with migraines, and various triggers like exercise, foods, exposure to light, and exposure to heat can also precipitate the onset of migraines. Migraine is a clinical diagnosis based on the criteria from the ICHD-3, ICHD being the International Classification of Headache Disorders. The diagnostic criteria are split into migraine without aura and migraine with aura. If there is no aura, a diagnosis of migraine requires a headache lasting 4 to 72 hours, at least one of the following: nausea and vomiting, photophobia, and phonophobia. They are also required to have at least 2 of the following here: a unilateral headache, a pulsating headache, a headache that is moderate to severe, and aggravation by exercise or exercise avoidance. The patient is required to have had at least 5 episodes that fit these criteria. If there are auras, there needs to be one or more of the following: visual, sensory, speech and language, motor, brainstem, and retinal aura symptoms. There also needs to be 3 or more of the following here: an aura that spreads over at least 5 minutes, a unilateral aura symptom, a positive aura symptom, so that's meaning something like scintillations or pins and needles, 2 or more aura symptoms in succession, each individual aura symptom lasting between 5 and 60 minutes, and a headache within 60 minutes of the aura. Importantly, imaging is only indicated in the presence of red flags, so things like systemic symptoms, focal neurological deficits, and sudden onset. Management of migraine can be acute or prophylactic. Importantly, prophylaxis is indicated if the migraines are recurrent, if there is significant functional impairment, if there has been no response to acute treatment, or if there has been recurrence despite a response. Acutely, NSAIDs are typically used to manage pain. Some of the key drugs used include aspirin, ibuprofen, and diclofenac. Antiemetics like metoclopramide can be used to help manage symptoms like nausea and vomiting. A triptan, that is a 5-HT1 agonist, can be added to the management if NSAIDs and antiemetics alone are insufficient. Importantly, these are contraindicated in cardiovascular disease because they can cause vasoconstriction. CGRP antagonists can be considered in these patients, or if there has otherwise been no response to triptans and NSAIDs. Prophylactic choices aim to alter the neurotransmission associated with migraines. Choices include beta blockers, tricyclic antidepressants like amitriptyline, and anticonvulsants like valproate. So that's it. Thank you for watching. Don't forget to like, subscribe, follow us on Instagram at MidnightMed1200 for more, and we'll see you in the next video.